Assalamu alaikum. So, welcome to our Breast One session. I'm Usman. So, our moderator will be Dr. Zishan Tarek, consultant clinical hematologist at Shaukat Khanum Hospital. He'll be online. Dr. Zishan, are you with us?
Yes, I can hear you.
Assalamu alaikum. So, also we have got our chair, Dr. Ataullah. Dr. Ataullah is assistant professor of surgery in Khyber Teaching Hospital. Alongside, we have got Dr. Jamshed. He will be he's a consultant medical oncologist at Shaukat Khanum Hospital, Peshawar. So, over to you, Dr. Zishan. The floor is yours.
Okay, good morning and Assalamu alaikum to all. First of all, I would like to welcome you all to 22nd Symposium of Shaukat Khanum at Peshawar. And I'll be moderating session one for breast cancer. And my co-moderator, Dr. Abdullah, will be hosting the second session. And I would also like to welcome our chair of the program, Dr. Junaid Sarfaraz. And without any more delay, I would like to go ahead and with our first presentation, which is on management of metastatic HER2 breast cancer. And our presenter is Dr. Danish Shafi. He is assistant professor at West Virginia University Cancer Institute, Morgantown in USA. He works in West Virginia. So he'll be presenting virtually. Let's go ahead and present his talk.
And I graduated from University, and currently I'm working as a medical oncologist in West Virginia University. And my topic for discussion is metastatic HER2 positive breast cancer. So I have no disclosures. So this next slide summarize all the treatment options we have currently in HER2 metastatic breast cancer. And I divide them into three categories, which include monoclonal antibodies, and those include trastuzumab, pertuzumab, and mirvetuximab. The second category is antibody drug conjugate, which we usually use in second and third line and beyond, including like TDM1, which was called trastuzumab emtansine, and the other one, which has recently been approved as a preferred second-line drug called trastuzumab deruxtecan or Enhertu. And the third category is TKI, which include TKIs we call like tyrosine kinase inhibitor, which include lapatinib, neratinib, and tucatinib. So this is the slide from NCCN guidelines, and it gives summary for treatment option in metastatic HER2 positive breast cancer. In NCCN guidelines, as you all know, whenever it is written category 1 with the treatment option, this is a preferred, as it has been shown by high level evidence that it works in patients. It is nice in a way that it shows treatment along with which line you can give. In stage 4 cancer, generally we treat cancer as long as possible with directed therapy. In first line, it is anti-HER2 combination along with single chemotherapy, and you can switch between Taxotere and Taxol, which is docetaxel and paclitaxel, based on sensitivities and side effects, and we have done on many patients. For second line, there has been a very exciting change in treatment, as previously it was TDM1, which was used, but now TTXT or Enhertu is used, and we will go over the trial which led to that approval and why it is preferred. Third line usually can give TKI along with anti-HER2 and chemotherapy, or any treatment that has not been used. In fourth line and beyond, as mentioned, optimal sequence is not known as any option that has not been used before is a good option, but as we know, the more we go down the line of treatment, patient prognosis and outcomes are not favorable. So now understanding and getting a general good like insight what treatments we have for stage 4 HER2 breast cancer, I would go over a few trials, especially for category 1 trials, and a few others to better understand how they got approval. I would go over quickly due to time limitation for this presentation. So my first study I would like to discuss regarding which is for the first-line treatment option in metastatic HER2 positive breast cancer, which includes combination of anti-HER2 along with chemotherapy, in which 1-to-1 randomization was done in comparison with placebo. It is just an anti-HER2 along with chemotherapy, and this trial primary endpoint was progression-free survival, and secondary analysis was overall survival. So as you see, progression-free survival is better in the combination of anti-HER2 compared to single agent anti-HER2 treatment along with chemotherapy. And you can see the hazard ratio is 0.69, and in months it's like 6.3 months. So that's a big difference. So also that trial was published in 2012 in NEJM, and then there was update a couple of years later, which it did show overall survival benefit with median overall survival benefit of around 16 months with dual anti-HER2 blockade, which was 56.5 months with combination versus 40.8 months when it was used with placebo. This trial showed us that starting with dual anti-HER2 is beneficial not only with progression-free survival, but also overall survival. So the second line drug which we use nowadays in almost everybody who progress on first line, and this has been recently changed from TDM1 to anti-HER2 with this drug. So going over, this drug is an antibody drug conjugate, a very new drug combination. The reason I say combination, it's like antibody along with the chemotherapy, and it is a linker. And the chemotherapy they use in this one is topoisomerase 1 inhibitor. So the trial that led to its approval in second line setting is called Destiny Breast 03. So any trial which has anti-HER2, the trial comes with the name of Destiny, and the cancer in which it was tried is the second name. So in Destiny Breast 03, patients who progressed on first-line treatment, which we just discussed, were randomized in 1-to-1 ratio between TDXT and TDM1 with primary endpoint of progression-free survival and secondary endpoint of overall survival with other and secondary endpoint you can see in the slide. So this phase 3 trial, Destiny Breast 03, compare TDM1 versus TDXT for anti-HER2. Patient with brain mets were eligible if they had clinically stable disease and the brain mets has been previously treated. At a median follow-up of about 16 months, progression-free survival by blinded independent central review was not reached with TDXT, and was 6.8 months with TDM1, risk reduction of 74%. The estimated 12-month overall survival was 94.1% versus 85.9%, with a hazard ratio of 0.5 with a p-value of 0.007, which did not cross the pre-specified boundary for significance. Other endpoints were similarly improved. And interstitial lung disease was definitely increased diagnosed in Destiny Breast 03. And the reason we think, because we are more aware about the side effect and we are checking now more, so that's why it's getting us more diagnosis of interstitial lung disease. It's not like the drug but it may change. It's still under review. Currently, the question arises if a patient is brain mets and they are not previously treated, what will be the treatment? Currently, there is a trial going on called like Tuxedo trial, in which they are checking if a patient has active mets and they progress on first-line treatment, what will be the if TTXT will work on those patients. And it has shown almost 73% response rate in those patients. But still, that treater is very immature to say anything. So Destiny Breast 01, so it moved from 1 to 3, and currently 4 is also recently approved. So Destiny Breast 01, it was published in NEJM. This trial was to see if TTXT those who have received trastuzumab in the past and pertuzumab in the past, and if they have any response from that treatment. So it was just to check the efficacy, like overall response rate, and there was some secondary endpoint as well. It was just like a trial to check the drug. So, and you can see like it leads to impressive overall response rate and also duration of response, and the waterfall is very impressive. So it did show in initial trial like it works. The median progression-free survival was 19.4 months, and overall survival was 24.6 months. And this slide shows adverse events with the drug. We did see with longer use of treatment to have more interstitial lung disease by 3 cases. But as I said previously, it may be more diagnosis. But the good thing is like it was not that much severe that led to the treatment discontinuation. Then the next trial is called Destiny Breast 02. This was trial to see if after the use of TTXT, if after the use of TDM1, if TTXT works or not. So this trial was comparison between TTXT versus treatment of physician choice. And primary endpoint was progression-free survival, and secondary endpoint of overall survival with other secondary endpoints as well, as shown in the randomization algorithm. So the median follow-up was 21.5 months in the trastuzumab deruxtecan group and 18.6 months in the treatment of physician choice group. And the median progression-free survival was by blind and independent central review was 17.8 months in the trastuzumab deruxtecan group versus 6.9 months in the treatment of physician group, with a hazard ratio of 0.36 with a p-value of 0.001. So overall survival was also significantly longer for patients treated with TTXT, 39.2 months with TTXT versus 26.5 months with physician choice treatment. This treatment was so good that 25.7% of patients receive TTXT, those who progress on physician treatment choice. So the trial that led to the approval of TDM1, it was for many years used as a second-line treatment in metastatic breast cancer. Currently, it is used in adjuvant setting for those patients who got neoadjuvant chemotherapy and they have a residual disease. And this was very fascinating trial. And so this trial showed that TDM1 improved overall survival outcomes compared with lapatinib plus Xeloda or capecitabine after anti-HER2 prior treatment without a significant risk for serious toxicity. So this trial enrolled around 990 patients with HER2 positive breast cancer previously treated with trastuzumab and taxane, 84% of whom had received trastuzumab in metastatic setting. and randomly assigned them to treatment with TDM1, which was 3.6 mg per kg IV, or a combination of Xeloda, which was like 1,000 milligram per meter square oral twice a day from day 1 to 14, plus Lepatinib, which was 1250 milligram oral daily, with each regimen repeated every 3 weeks. With a median duration of 19 months, TDM1 resulted in improvement in progression-free survival. Median was 10 versus 6 months, with a hazard ratio of 0.65. And also it led to the improvement in overall survival with a median of 31 versus 25 months, with a hazard ratio of 0.68. And a subsequent report of longer follow-up, more than 40 months, also showed improvement survival with TDM1 even in the presence of class-O treatment. And clinically significant improvement in overall survival, overall response rate, which was 44 versus 31%. And there were lower rate of serious grade 3 or 4 toxicity overall, 41 versus 57%, including diarrhea, hand-foot syndrome, like Palmer-Plantar erythrodysesthesia, and vomiting. And the most serious toxicity associated with TDM1 were thrombocytopenia and elevated liver function, including like AST, ALT, and the incidence of left ventricular dysfunction also declined to was also less than 50% in both treatment arms. So there was one interesting, I want to mention this because oncologists can experience that side effect. So patients with TDM1 in Amelia trial experience an overall higher rate of bleeding compared with those treated with Xeloda plus Lepatinib, though the rate of serious, like it was 30 versus 16%. So that was like a almost double bleeding risk. And though the rate of serious bleeding events was low in both arms, 1.4 versus 0.8%, however, the etiology of bleeding is not entirely explained by other risk factors like use of anticoagulants or concomitant thrombocytopenia. So in this trial, like for example, one patient showed who received TDM1 experienced grade 4 GI bleed despite having a normal platelet count. So based on these, the FDA revised the label for TDM1 in July 2014 to highlight the increased risk of bleeding, with recommendation for careful follow-up for patients during treatment with TDM1. So that was one interesting point I want to share, like you guys can experience. So this is like a third-line treatment, very commonly used in patients who have metastatic HER2 positive breast cancer, those who have brain mets as well. So this trial is called HER2 Climb trial, and that was just to check if tucatinib in addition to trastuzumab and Xeloda works better. So in this randomized trial, patients with HER2 positive breast cancer previously treated with trastuzumab, pertuzumab, and TDM1, and mostly like the median lines of treatment they used was 4 lines. Tucatinib, Xeloda, and trastuzumab improved both progression-free survival and overall survival relative to Xeloda and trastuzumab only. And this trial, 291 patients had brain mets at study entry, 174 of whom had active brain metastases, including both untreated and treated and progressing brain mets. So as you see, that addition of tucatinib led to improvement in both progression-free survival and overall survival. So FDA approved tucatinib in combination with trastuzumab and Xeloda for treatment of adult patients with advanced unresectable or metastatic HER2 positive breast cancer, including those with brain mets who have received 1 or more line of prior anti-HER2 regimen in the metastatic settings. Another trial called NALA trial evaluated the use of neratinib in a 1-to-1 ratio and compared with lapatinib in addition to Xeloda in both arms, which progressed on 2 or more lines of treatment. And the primary endpoint was progression-free survival and overall survival, and it did show both. So neratinib and Xeloda improved progression-free survival relative to lapatinib and Xeloda, which was 8.8 versus 6.6 months, with a hazard ratio of around 0.76. And overall survival rate were similar. Median overall survival of 24 versus 22 months, respectively, with a hazard ratio of 0.88. And one of the main side effects, I think most of you have encountered, diarrhea was the most frequent adverse events, with grade 3 diarrhea occurring 24% of patients receiving neratinib with Xeloda versus 13% with lapatinib and Xeloda. The other trial is called like Sophia trial. They use margetuximab, as we mentioned, it's an antibody drug, among 536 patients with disease progression after at least 2 lines of anti-HER2. The addition of margetuximab to chemotherapy was evaluated. So it led to progression-free survival with a median PFS of 5.8 versus 4.9 months, with a hazard ratio of 0.76. It's very minute difference, but still it's one of the treatment options available, and that's approved by FDA. So as I say, like, just it's a minute only benefit in PFS, no overall survival benefit. So that was a slide just to show margetuximab got approved in 2020 by FDA, and the reason I put a slide like it can give you a side effects of left ventricular dysfunction, and we need to follow the EF on those patients who are getting this treatment. So this is just like a schematic way how we currently treating patient with HER2 positive breast cancer. But the reason I want to show you one interesting point is it's not only HER2 positive, but those who have HER2 low. Currently, TTXT or Enhertu is also being used, and currently a lot of patients are getting Enhertu treatment. And I'm sharing this slide because this may be one of the treatment options for definitely Enhertu for the HER2 positive, but also all those patients who have low HER2 and you don't have other treatment options, but now in HER2 1+ or HER2 2+, this has been approved. So of 557 patients who underwent randomization, 449 had hormone receptor positive disease, and 63 or 11.3% had hormone receptor negative disease. In the hormone receptor positive cohort, the median progression-free survival was 10.1 months in the trastuzumab deruxtecan group and 5.4 months in the physician choice group. So almost double, and you can see the hazard ratio of 0.51 with the p-value of 0.00, less than 0.001, and overall survival was 23.9 months and 17.5 months respectively. So 6-7 months benefit. Hazard ratio was also 0.64, the p-value of 0.03. So among all patients, the median progression-free survival was 9.9 months in trastuzumab deruxtecan group and 5.1 months in physician choice group. Hazard ratio for disease progression or death was 0.5, less than p-value of less than 0.001, and overall survival 23.4 months and 16.8 months respectively, with a hazard ratio of death 0.64 and p-value of 0.001. So I just went over because time constraint, I didn't have that time to go into too much detail about this trial, but this is one of the trial you should be aware and should be bringing into your clinical trial or clinical practice. So now you can see previously anti-HER2 were approved in 3+ only HER2 positive disease, but now 2+ and 1+, we are using TTXT, and it's one of the very good option. And I prefer if I have that treatment option and compared to other treatment options. So a couple of slides just for your own clinical practice. So for patients who have treatment-free interval of 6 months or longer, like question arises, like if a patient is getting neoadjuvant chemo or adjuvant chemo, and they progresses, like they come up with headaches, they have a brain mets, they come up with a back pain, you do imaging, they have something there, and you do a biopsy, and suddenly become from stage 1 to 2 to stage 4. For patients with treatment-free interval of 6 months or longer, you do taxane plus trastuzumab, pertuzumab, like you use the first-line treatment in stage 4. And also, like question arises, if a patient is on TDM1, what if they have progression? So you can, if it's more than 6 months, you can still go back to the taxane, trastuzumab, and pertuzumab treatment group. And this is my last slide. So if a treatment-free interval is less than 6 months, you're giving treatment and patient progresses, then usually we go to second-line treatment. And in neoadjuvant, adjuvant, mostly we use trastuzumab, or in some cases TDM1, because that's what approved in residual disease, TDM1 in HER2 positive after they got neoadjuvant. So then we go to NHER2, which is TTXT, based on Destiny Breast 02 trial. So I think that's very important to understand and put in the clinical practice. So this ends my presentation for metastatic HER2 positive breast cancer. Please don't hesitate to ask any questions. They have my email and they know how to contact me. And I would love to meet you all in person. And thank you so much for your attention, and meet you soon.
Yeah, thank you very much, Dr. Shafi. It was a nice presentation. We would take all the questions at the end of session number 2. So we'll go to the next presentation. It's by Dr. Marcela Mazo. It's about treatment options of breast cancer in elderly and pregnancy. She is Assistant Professor of Medicine at the Department of Hematology and Oncology at Mays Cancer Center, UT Health, San Antonio, MD Anderson Cancer Center in San Antonio, USA. So if we can proceed with her presentation.
Hello, I'm Dr. Marcela Mazo Pinola. I'm a breast medical oncologist from Mays MD Anderson Cancer Center in San Antonio, Texas. And today I joined you from distance. I was unable to travel, unfortunately, but hopefully during the next opportunity, I'll get to visit your beautiful country. So today we're going to be discussing a very interesting topic. We're going to be discussing the management of breast cancer in 2 different but very challenging specific types of population. So we're going to talk about patients with breast cancer during pregnancy and elderly patients with breast cancer. These are my disclosures. So we're going to start by discussing the management of breast cancer during pregnancy. So the management of this patient population is very complex for multiple reasons. These patients are, for the most part, very young. They're starting maybe their careers. Maybe they had some sexual health and body image issues to start with. Maybe they have some mental health issues that are very common nowadays. They struggle to conceive this pregnancy, and they have waited for a long time, and now they're going to be faced maybe with some adjuvant treatments that will put them into a premature menopause. And us as physicians have to make modifications to their specific chemotherapy regimens, their endocrine therapy. We need to adjust to modify maybe the sequence or the type of local therapies that we do. So we have to pretty much play all these factors, and this all makes it extremely complex for the patient and for the physician. Fortunately, breast cancer is not very common. So we tend to see cancer in pregnant patients in about 1 to 1,000 pregnancies, with breast cancer being present in 1 to every 3,000 pregnancies. So in this slide, you can see some of the other cancers that we tend to see in this population. And to mention some, we also tend to see thyroid cancer, cervical cancer, some hematological malignancies, and not added in this slide, we also see some skin cancer, including melanoma. So breast cancer diagnosis during pregnancy, or BCDP, as I mentioned a moment ago, is an uncommon event, fortunately. And it represents about 0.4% of breast cancer diagnosis in patients between the ages to 16 to 49 years old. And in the younger group, patients in between 25 to 29 years old, one out of 5 of those patients are going to be dealing with breast cancer in a pregnancy. We probably are going to see more cases of breast cancer during pregnancy. And this is because a lot of women are delaying the start of their maternity, and they're waiting longer to, start looking for those children. I would like to make some differentiations as far as definition. So the big bag, it's an entity known as pregnancy-associated breast cancer, or PABC. And this has been classically defined as a breast cancer diagnosed during pregnancy, lactation, or up to a year after delivery. However, there's new data coming that is thinking of splitting this definition into 2 different and distinct subgroups. So one is called breast cancer during pregnancy, or PRBC, and the second group is defined as breast cancer postpartum, which is supposed to be defined to the postpartum period up to 5 to 10 years. So this definition is coming more into play because there seem to be some differences in outcome in these patients that I'm going to mention in a moment. So this slide kind of summarizes what I just said up to this point. So breast cancer during pregnancy tends to be relatively uncommon. Breast cancer is one of the most common type of cancer that we see in pregnant patients. And we tend to see that pregnancy-related breast cancer seems to have pretty similar outcomes to non-pregnant patients. However, as I hinted a moment ago, postpartum breast cancer seems to behave a little bit differently and tends to have apparently a worse prognosis. So postpartum breast cancer, it's supposed to be defined as the cancer that happens from delivery up to 5 to 10 years. We speculate it represents about 35 to 55 of our patient population, and it seems to be associated with worse survival. These patients have supposedly increased risk of metastatic disease, and overall they do worse. The reasoning for that is behind what happens on the breast when we're lactating. So in different animal models, we have seen that after a woman's breast prepares for breastfeeding, there are some changes that naturally the breast goes through. And as those changes fade away and the breast goes back into its normal state, it seems like the microenvironment of that specific breast makes it more prone to have an aggressive cancer, and it makes it more prone to cause a breast cancer that will be likely to metastasize. This is still very early, and more research is needed to confirm if this definition is going to be the one that we're going to use, but just know that this is something that is coming. Most of the management that I'm going to be discussing during the rest of my presentation will be associated with pregnancy-related breast cancer. So this Kaplan-Meier shows you what we have been speculating before. This was published in the Lancet in 2021. So in this graph, you can see the big differences in survival, with the blue line showing you what we refer to as pregnancy-associated breast cancer, which is the basket that probably has some overlapping in between pregnancy-related breast cancer and postpartum breast cancer, but you can definitely see that there seems to be a worse survival with patients with postpartum breast cancer. So let's jump in and start working on diagnostic considerations and management. So it's important to know that any lump or new symptom in a pregnant patient needs to be evaluated by X-ray hands. So there's no secret that during pregnancy, a woman's breast is going to go through some changes, and maybe they will go to their OB or to their practitioner to tell them, you know, I have this lump, I have this change in discoloration. And the bottom line is that any change that that woman is expressing needs to be evaluated. We cannot assume that it's just related to pregnancy. So the first step to do this evaluation is to proceed with a breast sonogram. Coordinated biopsy is safe during this situation, during pregnancy. If for whatever reason your sonogram is non-diagnostic or you need more imaging, mammography is another test that you could do. It requires abdominal shielding to protect the fetus. In some reasons and some circumstances, I'm sorry, MRI will be necessary. The important thing to know is that MRI is safe, but gadolinium cannot be used because that gadolinium can potentially cross the placental barrier and could harm the fetus. So if you need to do an MRI because that's going to change your management or your surgeon feels that they need an MRI, they can do it, but just be mindful that gadolinium cannot be used. So after diagnosis has been made, as far as the staging test that we recommend, so we recommend to use a chest X-ray to look for any potential disease in the chest. You can do a liver sonogram to assess for liver metastases. And if there's any concern for potential bone mets, you could consider doing a non-contrastive skeletal MRI. Note that bone scan and nuclear tests are not safe to be used during pregnancy. So you're really going to need a team of multiple people helping you with the management of this patient. So contact radiology early in the process to see what's the best test for your patient. Talk to your pathologist to expedite diagnoses. It is imperative that you discuss the case with your surgeon and your radiation oncologist to find out what's the best ways and what's going to be the best way to sequence the treatment for this patient. Your pharmacists are going to be key, as they're going to help you to give that patient safe chemotherapy and safe supportive medications during the time that they receive the chemotherapy. Become friends with your OB. This patient should be ideally seen by a high-risk OB, and communication in between oncologist and OB is a must. There are also some ethical and legal, issues that the patient might face. So getting your social worker and of course the patient's loved ones is going to be imperative for successful management of this patient. So what are our goals really? So we want to do an effective treatment for the patient, and we want to minimize the toxicity for the fetus. Inevitably, there's going to be some risks that you have to discuss with your patient. So there are going to be some risks to the fetus, the chemotherapy, the surgery, maybe hormones, maybe short-term toxicities and long-term toxicities. So it's important to disclose that to the patient. There's also going to be some risk to the mother. They're facing a disease that could be potentially lethal. It's not the same if the patient is dealing, for example, with a stage 1 cancer rather than with an inflammatory triple negative breast cancer. So having a discussions about, what to expect is very important. So let's dive in and start talking about treatment. I'm going to start my discussion discussing surgical considerations in the management of these patients. So in general, surgery can be done safely at any stage of the pregnancy. And we have evidence that supports the use of anesthetic agents in any trimester, and that has deemed as being safe for the unborn fetus. It is important, like I mentioned a moment ago, to have a discussion with your surgeon as far as what's the best way to treat this patient and what's the best way to sequence the surgery if needed to be. And basically, you're going to take into account the clinical stage, the type of cancer that you're dealing with, if the patient has any genetic mutations, and of course, their gestational age. Not the same if you have a patient that is just starting a pregnancy rather than a patient that is in their last trimester. So classically, it was discussed that mastectomy was a standard of care for the surgical management of breast cancer patients. However, we have new information and new evidence that suggests that the use of breast conserving surgery is just as effective in this patient population, with the caveat that there's gotta be delayed radiation therapy. So there is a prospective evaluation done by NDM Cancer Center in Houston, in which they treated patients with mastectomy for breast conserving surgery for early stage breast cancer. And breast conserving surgery performed just as well as it would with a non-pregnant patient. So note that that's an option for you to discuss with the patient, taking into account that the timing of radiation has to be postpartum. How about sentinel lymph node biopsy? So in the past, most patients used to go straight for axillary lymph node dissection. However, we have learned with different studies that sentinel lymph node biopsy is safe in this patient population. So we have learned that the observed doses of radioisotopes for this patient is extremely low, and it's deemed to be safe for the fetus. It is preferable to use radioisotopes rather than blue dye, as blue dye is deemed as a category C, and some anaphylactic reactions have been reported. So in the event that in the particular patient that we're treating, you're going for a sentinel lymph node biopsy, we recommend that you stay away from the isotopal blue dye, as it's not reported to be safe in pregnancy. So this is a publication by the Annals of Surgical Oncology in 2014. This was a small patient cohort, but that still says a lot about the use of sentinel lymph node biopsy in this patient population. So as you can see in the graph, they were able to get the mapping done with accuracy in patients across all trimesters. However, if you look at the table, you will see that these patients had more incidence of axillary lymph node dissection compared to the general comers in the same situations that were not pregnant. And of course, since they have more lymph node dissection, they're going to have more lymphedema. So message here is to remember that sentinel lymph node biopsy is an option for your patients, and you can offer breast conserving surgery in those patients that are appropriate for it. Let's jump into radiation therapy. So radiation therapy in pregnancy in general is contraindicated. If for whatever reason some radiation is considered, there's gotta be shielding. The fetal exposure to radiation is usually between 0.1 to 0.3 of the maternal dose. So for example, if a woman is gonna get a dose of radiation of about 50 gray, the fetus is gonna get 0.3% of that. Keep in mind that that number will increase as the fetus grows because they'll have a bigger body surface area. So if for whatever reason radiation is pursued, the dose should be less than 0.1 gray, because that can cause teratogenicity to the baby. And in general, the recommendation is to stay away from radiation until after the time of delivery. There's also some questioning about what to do with lactation when the patient needs radiation. And the truth of the matter is that we don't have any evidence that supports the breastfeeding babies when women are going under radiation. So usually the recommendation is to avoid breastfeeding during radiation. Okay, so let's jump into the systemic therapy. So this is when things, of course, get a little bit complicated more, and we all get a little bit anxious and nervous about treating these patients with chemotherapy. So I would like to split out basically in between three options that you have when it comes to systemic therapy. So you have the option of deferred systemic therapy until the time of delivery. So this is something that is usually applied in patients that are towards the end of their pregnancy, or if the patient has a very strong preference to wait, with clear discussion about the repercussions of that decision. You could then also start chemotherapy during the pregnancy. You will have to make some modifications, some treatment schedule changes, and consider other treatment regimens to treat that patient. The third option is termination of pregnancy. There is no data that supports the use of termination of pregnancy as a tool to improve survival. We don't have any data that proves that. And obviously, it's something that you're going to have to discuss with the patient, and it will depend on what place of the world you are, if you can have a termination or not. And it's also something that should be discussed with the patient if they're struggling with mental health, or if the patient is, having an increased risk of a bad outcome. So these are, in general, the chemotherapies that are deemed to be acceptable and safe during pregnancy. So some of these drugs are not drugs that we usually use in breast cancer treatment, but just know that the big ones that we tend to use the most, so anthracyclines such as doxorubicin, cyclophosphamide that we also use in breast cancer treatment. There are some that we absolutely don't use, which is methotrexate and cytarabine. Those are not acceptable during pregnancy. I would like to point out that the use of taxanes is becoming more acceptable, and we're having more data supporting the use of taxanes in pregnant patients. So important to know, during the first trimester, we usually don't give chemotherapy. That's in between week 8 to week 12, because that's when the organs are forming. It is not safe to give chemotherapy during those times. But during the second and third trimester, since basically the baby is growing and is maturing, it is acceptable to use chemotherapy in those circumstances. So some rules of thumb to keep in mind. So it's important to keep your dose intensity. So keep the timing that you're supposed to have for the treatment regimen that you select. Go with published standard protocols, and we're gonna spend some time talking about this. You should dose the chemotherapy according to the actual body weight. Remember that there's gonna be some changes in the pharmacokinetics and how the drug gets distributed in this patient population. So make sure that you dose according to the body weight and talk to your friendly pharmacist. Do not increase the dose. You should not increase the dose based on, the increase in weight of the pregnant patient. Again, it's an important discussion to have with your pharmacist. And it is recommended that you discontinue chemotherapy between weeks 35 to 37 to allow a safe delivery and to avoid potential hematologic toxicity for the patient and the fetus. So this is the experience from Dana-Farber. So this is a report that came out in 2013, big cohort of patients. It was retrospective. However, they were able to capture 68 patients. Of those, the vast majority of them, 53% of them, received chemotherapy. As you can see, all of them received chemotherapy in their second and third trimester. And the different treatment regimens that they use, you can see them on the screen. So some patients receive AC every 3 weeks. Some patients receive AC followed by paclitaxel. Some were considered for neoadjuvant chemotherapy as well. And there was some also use of growth factor support in this patient population. And as far as their outcomes, actually 3 babies out of those 68 had some fetal abnormalities. And this is consistent with what we see in the general population for patients that are not suffering with breast cancer. And we did tend to see that some of these babies were born a little bit sooner, although when they were looking at the charts to see what happened, in about half of the cases, they were born as a preterm because they were trying to facilitate the care of the mother. There was an updated report by the same group. This was published in 2022. So it was a larger cohort of patients, 139 pregnancy-related breast cancers. So those patients, 60% of them were exposed to chemotherapy. 22% of them received taxanes, and a higher percentage of them also received growth factor support. They were also disclosed in this publication that the use of taxanes and the use of growth factor support increased over time, seeing higher numbers in those patients that were capturing between 2020, 2021, 2019 compared to prior years. So looking at different treatment regimens, so this is something that was published in the Oncologist in 2017. So we kind of talk about the use of AC, the use of paclitaxel. There's also some other treatment regimens that have been described. For example, there is a report from MD Anderson Cancer Center in 2006 with the use of FAC, that's 5-FU, with adriamycin and cyclophosphamide, 4 to 6 cycles in these patients. And so you can see in the table, the median gestational age of delivery was 37 weeks. They didn't appreciate any excess, bad outcomes for the babies. They did not describe any miscarriages, stillbirths, of any deaths. There was also a German group that published a series of cases with the use of CMF and with the use of anthracyclines and taxanes. And you can see also that those patients did not have an adverse outcome compared to the peers that are not suffering with cancer. How about targeted therapies? So every here and then, you're going to deal with a patient that is HER2 positive. And unfortunately, trastuzumab is something that has a black box warning here by the FDA about its use in pregnancy. So in those cases that trastuzumab has been observed or as an exposure to a baby, this has been associated with oligohydramnias, renal dysfunction in the fetus, and even newborn death. So basically, there's no data in the use of Herceptin, Perjeta, or trastuzumab in this patient population, and the recommendation is to avoid its use until the patient finishes the pregnancy. How about supportive anti-nausea medication? So in general, the 5-HTT3 antagonists, the one that we have the most experience with is ondansetron, and that's the one that our institution, we tend to use the most when we have a pregnant patient. Other medications such as the NK1 inhibitors, we don't have enough data to use them. You also have the resource of using steroids for nausea prevention, and the one that has the most experience is methylprednisolone, and that's usually the one that we use in our cancer center. And other medications that we have used include PPIs and H1 and H2 blockers, and they seem to be safe, although there's not a whole lot of data behind their use. GCSF, as I mentioned a moment ago, its use is increasing more and more, and it's something that seems to be safe for the fetus and the mother, and there were no reports of splenomegaly or splenic ruptures that we were able to identify in the literature. How about hormone therapy? So tamoxifen, it's basically something that we give to patients after they complete their definitive treatment, and we use it as an adjuvant therapy. However, its use during pregnancy is contraindicated. There have been some reports of malformations in babies, especially malformations in the genitalia. So basically, we avoid its use. If a patient has finished treatment for breast cancer and they are in the process of wanting to conceive a baby, they should be off tamoxifen. Or if they're taking tamoxifen, it's important to discuss contraception in those patient population. As far as the aromatase inhibitors go, there's no data to ensure their safety during pregnancy, so we recommend against their use as well. And this graph basically kind of summarizes what can be given during a given trimester. So during the first trimester, basically, the patient is not aware that they're pregnant. They kind of put a dashed line in between radiotherapy, but the rule of thumb is you should wait for radiotherapy to be given after the patient delivers. Chemotherapy is safe in the second and third trimester, and breast surgery and sentinel lymph node biopsy can be performed at any point during the pregnancy. So our conclusions are that for patients diagnosed with breast cancer, the goal is to try to stay as close as you possibly can to the protocols that have evidence behind them. The prognosis of pregnancy-related breast cancer seems to be the same as non-pregnant patients. However, we are facing potentially a worse prognosis in those patients that have been deemed as postpartum breast cancer, but this is an area that needs more research. We can successfully perform some local treatments to these patients during their pregnancy, including sentinel lymph node biopsy, a surgery, and we can give chemotherapy in second and third trimester. And the use of other therapies such as CDK4/6 inhibitors, PARP inhibitors, immune checkpoint inhibitors, we don't have any data as far as the safety during pregnancy, so we avoid them. And lastly, it is important that you really work as a team, that you get all the team members working together, communicating together to have a successful treatment for these patients. And I couldn't, of course, say nothing about the prostate trial. This is something that we were all waiting for a long time. So this is a study that looked into the pregnancy outcome and safety of interrupting endocrine therapy. So these were patients that were with history of treated hormone receptor positive breast cancer that were put on treatment with the GnRH analogs with SERMs or AIs. And basically those patients interrupted their hormonal therapy after 2 years and they attempt pregnancy. They enrolled 516 patients and the vast majority of them were younger than 44 years old. And basically we're happy to see that the breast cancer-free interval and basically showed no difference, basically pointing out that it's perfectly safe for these patients to interrupt their endocrine therapy and have successful pregnancies. Okay, so we're gonna jump and we're gonna talk about management of breast cancer in the elderly patients. So this is another population that is challenging. Why? Because the biggest risk factor for breast cancer there is aging. And there is a wide spectrum of women that are considered to be older. So we have 65-year-olds that are extremely ill, that don't have a good performance status. And we have 75-year-olds that are fully independent and they are very fit. So there is a big heterogeneity in this population. Older populations are underrepresented in the landmark clinical trials for breast cancer. So not a whole lot of those patients were included in those clinical trials. And it's a fact that usually older patients receive less aggressive treatment compared to their younger peers. So my recommendation will be to start the evaluation of your patient with a frailty score. So there are several in the literature. Probably the one that we know the most is the comprehensive geriatric assessment. I have used it sometimes. I think it's a little bit difficult to actually do this score. There are some others, the SAOP2, the G8, also some groups such as the Cancer and Aging Research Group for Breast Cancer have come up with calculators to give us an idea of the potential toxicity from chemotherapy. I personally have used this ePrognosis. It's a resource out of UCSF that can give you a very nice evaluation of the frailty score of an elderly patient. So basically use the one that you feel more comfortable with and the one that you feel is easier or more appropriate for you to perform. So you can also resource to use this chemotherapy toxicity calculators. These are the ones that we tend to use the most, the CRASH tool and the CARG chemotoxicity calculator. They include certain variables to give you an idea of more or less what kind of toxicity you can expect from a certain regimen. So this is important to mention. What about germline screening in this patient population? So for example, you have a patient in their 70s that is presented with triple negative disease, or they have metastatic disease and you really are thinking about doing that germline screening. So those patients actually do meet criteria. It is important to remind yourself that those patients are going to be 3 times less likely to have a germline mutation, but they still can have it. And in some cases that can affect management of their, of their condition. So in the ones that end up being tested, BRCA2 and CHEK2 seem to be the most prevalent germline mutations that we see in this population. The recommendation will be that depending on the patient that you have in front of you, you could consider offering germline testing or not. But it's something that, for example, here in our cancer center, we tend to do if the patient is motivated and interested in the test, or if we feel it's going to change their management. So let's talk about considerations for surgery. So usually these patients are, if they're good surgical candidates, the procedures that we do will be the same that the ones that we will do for patients that are much younger. I would like to point out some considerations for you to keep in mind when you approach this patient population. So in patients that have a limited life expectancy, one could consider the use of endocrine therapy if patient has a very strongly positive hormone receptor cancer that is low grade. If you feel that that patient is not going to live more than 5 years, it is a very reasonable alternative to offer. And it's something that is supported by the literature and by the SIOG Society, which is the International Society of Geriatric Oncology. and also by other groups that come up with guidelines to treat this specific patient population. In this population, we tend to use less invasive approaches. So especially if the patients have no evidence of lymph node disease. Axillary clearance in this patient population does not produce any survival benefit, and it's very rare to see regional recurrence in these patients. So here in the US, we tend to spare patients from sentinel lymph node biopsy and they're older than age 70 to 75. And this is part of the ASCO Choose Wisely campaign, in which we tend to kind of de-escalate the treatment of this kind of older population. How about radiation therapy? So the landmark study that looked at this issue in geriatric population was the CALGV 9343 trial. So this basically the study looked at the incidence of local regional recurrence after they did a 12-year follow-up. And they did see maybe a little bit more of recurrence, 10% versus 10% versus 2% in patients that did receive radiation versus the ones that did not receive radiation. However, this difference did not translate into any survival benefit. So our guidelines, NCCN and NICE guidelines, now advocate for the omission of radiation therapy in patients that have low risk disease. For example, older patients more than 70 years old with no negative disease that are candidates for endocrine therapy, or patients that have very small tumors that are strongly hormone receptor positive, and that again that will receive endocrine therapy will be the ones that maybe you could consider sparing radiation. How about systemic therapy? So this study was published in Lancet Oncology in 2020 and looked specifically at the treatment of triple negative breast cancer in patients that were older than 70 that had stage 1 to stage 3 disease and that received any kind of surgical intervention. So I want to point out here in the graph that you're seeing, that table. So the number of patients that they got was pretty impressive. That's 16,000 patients, and they divided their outcomes into 3 different columns: patients that did not get a recommendation for chemotherapy, patients that received chemotherapy, and patients that had chemotherapy recommended but decided not to get it. So as you can see, when you look at the group in between 70 to 74, those are the biggest percentages as far as patients receiving chemotherapy. So we tend to see younger patients within the same category as the ones that receive more chemotherapy. And they use all sorts of sequences. Some patients receive neoadjuvant chemotherapy. Some receive chemotherapy in the adjuvant setting, which is about 80% of the cases, as you can see in the screen. And they've had, different surgical approaches: lumpectomy versus mastectomy, and radiotherapy was actually given to the vast majority of them, as you can see. So what happened with their survival? So when they checked their 5-year estimated overall survival, 68% of patients that received chemotherapy were alive. 61% of the group that was recommended but did not receive chemotherapy were alive. And patients that did not receive chemotherapy, 53.7% of them were alive. And you can see the nice separation of curves in the Kaplan-Meier favoring the use of chemotherapy in this patient population. And they also did this regression analysis comparing the patients that received chemotherapy versus the ones that were recommended but elected not to get it. And they did see an improvement in overall survival. So this kind of justifies the role of using chemotherapy in certain aggressive histologies, such as triple negative breast cancer. However, you will have to individualize the patient that you have in front of you to determine if they're going to be a good candidate or not. Okay, so switching gears and looking into the standard chemotherapy regimens. So in this study, this is the CALGV 49907. This was published in 2019. they basically, what they did is they enroll 600 patients and they randomize them to receive what we call standard chemotherapy, which will be regimens such as CMF, AC, and compare it to other chemotherapy such as capecitabine. This is what they decided to use as their intervention arm. And basically, patients that received capecitabine were twice as likely to have relapse and twice as likely to die compared to the patients that received standard chemotherapy. Of course, because they received more intense chemotherapy, higher toxicities were seen in the patients that received CMF or AC, and most of those toxicities were hematological in nature. How about if your patient is high risk? For example, they have multiple nodes, they're very locally advanced. So if the patient is medically fit, you could consider an anthracycline taxane regimen, but be aware that those patients are probably going to have more evidence of toxicity and more cardiac toxicity. So this is something that was published in 2017 in JCO, and we really give cardiac toxicity to those patients. So in those ladies that were aged to 66 to 7 years old that received an adjuvant anthracycline had significant higher rates of congestive heart failure. So even when they look at the 10-year cutoff for follow-up, that difference continued to widen and widen. So in the right patient, it's something that you can give, but just be mindful that those patients have an increased risk of having cardiac issues down the road. And that's something that you're going to have to discuss with that patient. HER2 positive disease. So we know that the addition of trastuzumab really improves outcomes in patients because it decreases risk of recurrence. However, those patients are going to be more prone to have cardiac effects. Other HER2 blockers, such as pertuzumab, have been added to the neoadjuvant treatment protocols and some of the adjuvant treatment protocols. However, pertuzumab is an agent that is notorious for causing diarrhea, and that's something that could affect this patient population significantly. I will also point out that the biggest benefit of pertuzumab is those patients that are node positive. And really, for you to see the big difference by the addition of this agent, it will be for those patients that receive your regular neoadjuvant TCHP, and then they were later offered pertuzumab as well in the adjuvant setting. So it will be in a case-by-case basis. If you feel that your patient is high risk and they're very fit, it's something that you could offer, but just be aware that there might be more toxicity. Usually the neoadjuvant regimens are not used as much in this population. And I will also want to point out that when it comes to other agents, such as the use of TDM1 in the adjuvant setting for those patients that don't have any PCR, the percentage of geriatric patients enrolled in the Catherine trial was very small. So it's something that you could offer to a patient that you feel is fit, but again, it's something that will probably increase toxicity. So this graph kind of summarizes, what are the chemotherapy regimens that we can use in HER2 negative and HER2 positive disease. Point out that, capecitabine has no indication, as I explained a moment ago. In patients that have HER2 positive disease, you could consider the addition of trastuzumab to some chemotherapies, depending on the patient that you have in front of you. And we encourage also the use of G-CSF and growth factor support for those patients, as they may have more hematological toxicity. How about metastatic patients? So basically, the decision of treating a metastatic patient, it will depend on the performance status of that specific patient and their desires. What are their goals? What kind of network support do they have? What do they want? So if you elect to offer patient chemotherapy, it is recommended to do single agent regimens rather than multiple chemotherapies. If they have hormone receptor positive disease, CDK4/6 inhibitors with endocrine therapy, since they are the standard of care, as we all have used them. It's something that for the most part is very well tolerated by this patient population, although be aware that there might be some more toxicity. If your patient has HER2 positive disease, you could consider the addition of medications such as trastuzumab or other HER2 directed agents, being mindful of the cardiac toxicities. And remember that some of those patients are also going to have some hormone receptor sensitivity, and they might be candidates for endocrine therapy as well as part of your treatment. So to manage these patients, in conclusion, be mindful of how heterogeneous this population can be. So you really have to individualize care for a specific patient that you're dealing with. Involve a multidisciplinary team, and try to basically partner up with the patient and their support network, and be mindful that unfortunately, most of the big trials that we have did not include a lot of geriatric patients. So sometimes we have to extrapolate what we know from patients that are younger and just, account that in your decision making. And with that, I'll stop my presentation, and I'll thank you for your attention, and I hope that you enjoy it. This is my email. If you have any suggestions, any questions, I'm happy to hear from you. Thank you so much for having me.
Thank you very much, Dr. Marcela, for this wonderful presentation. So before moving to our next presentation, I would like to also announce that after this presentation, we would have a break for our lunch as well as prayer, and we will regroup at 2 p.m. inshallah. So let's present our next presenter, who is Dr. Zishan Ansar Ahmed. His presentation is also virtual. He'll be talking about prognostic markers of breast cancer, and he's assistant professor of molecular pathology at Khan University. So if we can proceed with his presentation. Thank you.
Inviting me for a wonderful symposium on breast cancer. I'm going to discuss about the predictive and the prognostic marker of breast cancer when to use. Sorry. I have nothing to disclose. I'm going to discuss the breast tumor biology and biomarker, application of molecular diagnostic in breast cancer for interpret the germline and the somatic mutation, the key biomarker and their modalities, limitation and potential resources of error. So before starting the biomarker, I'm giving a brief overview about the breast cancer. So breast cancer is the second most leading cause of the women mortality. Every 8 women develop the breast cancer in US. 6% of them are diagnosed as a metastatic disease, and their 5-year survival is around 29%. This is the around 40 years mortality data. So with passing of time, the mortality is decreased because of better awareness, the better screening system, and the improvement in the treatment, and even the improvement in the diagnostic mechanism also. For tumor biology, so to understand the tumor biology, we understand the whole mechanism of how the genetic control is actually on the cells, and any pathology is which is developed at the DNA level, it's basically effects on a gene. So gene is basically a basic unit of the cellular mechanism, and which is basically controlled by the DNA arrangement. So if the DNA arrangement or any error occurring in the DNA sequence, it's expressed over the gene, and gene is control the whole mechanism of cell cycles. So it will affect the protein expression or alter the protein expression, and that protein is basically the building blocks of the tissue. So it expresses the morphology of tissue, and that's how the tumor is behaving as a clinical phenotype. So that alteration is basically utilized as a biomarker for majority of the tumor, and it helps for prognosis and as the predictive marker for the treatment. So for DNA and the RNA identification, or the DNA and RNA changes identification, is usually done by molecular pathologist or molecular technique, which is fluorescent in situ hybridization, microarray, and the real-time PCR or the conventional PCR. But the changes at protein and the cellular level is usually picked up by the gross examination and the morphological or the microscopical examination, which is immunohistochemistry, and the HNE and other histopathological work. So this is how basically we understand the tumor biology, the clinical behavior of the tumor, and its therapeutic response. So there is a history, around more than 50-year history of these markers, and how they evolve, from low sensitive marker to the high sensitive technologies or modalities, and it's take around uh, decades to establish these potential oncogenic driver, or these potential oncogenic driver as a actionable mutation in a panel wise, or in a panel, large gene panel, by Sanger sequencing, by next generation sequencing, in a form of targeted panel, in a form of uh, long read, sequencing by for BRCA and the PIK3 and other, gene. So based on these biomarker, we categorize the disease for prognosis and its predictiveness. So majority of the breast cancer in an initial workup, they usually done for ERPR and the HER2, and the ERPR is the most common one, and it has its role for prognosis and the predictiveness, but the remaining one will have low prevalence. Some of them have a predictive value, some of them have the prognostic value as well. And based on these marker, actually, we categorize the breast cancer in a molecular level, like luminal A type, luminal B type with HER2 negative, HER2 enrich, non-luminal type. So in these all, those who have the high ERPR positiveness, having good prognostic, and they have a high prevalence. But the remaining who has the high Ki67 positivity, or the having a high doubling time, have the bad prognostic, progress. So based on the literature, or the recommendation, they are going to include the more marker. For majority of these marker are using for the recurrence risk of the disease, which has the in a panel form of different gene, or these gene are the targeted gene, not the end-to-end sequencing. And some of the immunohistochemistry marker also having a role for prognostic and the predictiveness, like PDL1 expression and the Ki67. But the PIK3 one, they using by PCR and the sequencing as well for the recurrence stage of the disease, and or they having associated with as a targeted agent for different therapy which is introduced last few years. And there's few marker which is under investigation, like MYC overexpression on amplification, tumor infiltrating lymphocyte density in patient with a recurrent disease, estrogen receptor mutation. There is a lot of work is going on the circulating tumor cells, circulating tumor DNA, homologous recombinant deficiency, and the FGFR and TROP2 expression. So these guideline is basically, the NCCN and the ASCO or the CAP with the AMP. So the NCCN recommendation is usually for the patient clinical decision or the treatment decision. For example, the patient with the breast cancer are eligible for some therapies or eligible or appropriate for some specific test, but the CAP and the AMP, guidelines or the recommendation are for biomarkers, sensitivity, validation, precision among the different laboratories. So they basically validate these type of tests by different, resources, and then they establishing a special through their validation process, and then they put it for testing guideline. So they recommended that initial stage, most of the guideline recommended that the ERPR, HER2, and the PDL1 should be done, but in the recurrent stage, PIK3 and germline BRCA is recommended. Based on their status, they are also recommended to do additional biomarker testing, like in case where the HER2 positive with HER2 negative with ERPR positive, the PIK3 mutation is also very important. Like for other triple negative breast cancer, the PDL1 expression is prognostic and the predictive role, and the BRCA again testing is always, and it has a role for the somatic and the germline testing. So there are different approaches to use these modalities to check these markers. You can do the large gene panel, you can do the whole genome or whole exome. The whole exome means that they only targeting this, the coding region of the gene, not the intronic one. They can compare the germline with the somatic. You can do the liquid biopsy, but liquid biopsy is usually recommended up till now for the follow-up monitoring. They emphasize or they recommended that the initial workup should be done on the tissue, but there is still discussion is going on. So they also having the targeted panel for like oncogenic driver or the actionable mutation. So all these approaches is used for primary diagnosis, for predictive and the monitoring the recurrence of the disease. In hereditary breast cancer, there is around 5 to 10 female breast cancer are reported, and 4 to 40% reported in the male breast cancer. And there is a gene with high risk breast cancer are usually the BRCA gene, TP53, PTN. They are the high penetrating gene, but still there is a gray area which is unexplained of these high risk occurrence in the different type of population or the group or the ethnic origin. So these inherited susceptibility of the cancer, you already knows better than me that these cancer is more closely occurring and the close relative. Multiple generation is affected. They usually occur at the early stage, having a multiple primary tumor. They usually cause the bilateral disease and special especially affecting the ethnic background origin. So these hereditary breast cancer available for those who have their history of BRCA positive. They recommended the do the BRCA first, and if the BRCA is negative, there is the non-BRCA panel which has TB53, and CDH1 and the PARP2 gene and the CTK11. For modalities, so I'm going to.
It's a Juma prayers time approaching shortly at 1:30. So what we would do is it will resume this session. It's a recorded talk at 2 o'clock. So please welcome back at 2 o'clock. Assalamu alaikum and good afternoon. Welcome back. So we'll be resuming our session after Juma prayers of Dr. Zishan Ansari's talk of breast cancer.
Like the Sanger and the Sanger, these sequencing is usually 3, and then come to the PCR1 and the PARP2 gene and the CTK11. For modalities, so I'm going to little bit focusing about 3 and then come to the PCR. So there is a sequencing modalities and there is a special the variant modality which is be done by the PCR. So in sequencing, there is 3 type of sequencing. First generation sequencing like the Sanger and the Sanger. These sequencing is usually for the small gene. The base pair of the gene should not be more than 1,000 base pair, and they need the high percentage of tumor and high percentage of variant allele frequency. Otherwise, then the subclonal thing will be loose. But the advantage of next generation sequencing that if the percentage of tumor in the tissue is very low and it has the low VEF, so it will pick by the next generation sequencing, and the most the beneficial thing by a next generation sequencing that it can read the long million base gene sequencing. So now the next generation sequencing is more recommended to do for the routine testing, and hopefully it will part of the routine testing in all over the world. For PCR testing is basically for a special variant or a special type of hotspot, because PCR will not sequence the gene. It will only pick which the PCR have the primer for that mutation. Like for example, if there is some point mutation common in the PIK3 or the BRCA, you can easily pick by the to establish a primer of these. But again, the you need some percentage of the tumor in the tissue, but the sensitivity of PCR is higher than the remaining previously I discussed sequencing and the next generation sequencing, because it's a primer base testing. There is some imaging available for breast cancer like fluorescent in situ. We use the probe for that genetic aberration, for example HER2, and but it need the expertise to interpret the cells or nuclei. Similarly, the ISC is also utilized for ER and PR. Again, it needs the robust process and the expert person to interpret the ER/PR expression and the HER2 expression as well. For BRCA, usually recommended nowadays by NGS, because BRCA is 1 and 2 both are very, very, large gene. It cannot be done by the whole gene sequencing cannot be done by PCR or the Sanger. And it's usually indicated for those women who has the high risk of breast cancer in their families, the high risk group of the families, which previously reported the BRCA positive, and it is also indicated in those patients who may eligible for the treatment of PARP inhibitor. So there is a different, hotspot available. People can do the targeted panel, but it need a long literature based, a recommendation to identify or to establish the targeted panel of BRCA, and it will help for, the specific group of population or a specific group of uh, uh, group of the group of people. PIK3 again is very common now because the targeted agent is available. So the important of PIK3 that 36% of all patient is of breast cancer is positive for PIK3, and 42 patients with the HER2 positive, HR hormonal receptor positive and HER2 negative, 31% patient with the HER2 positive disease, and 16% is the PIK3 is positive in triple negative breast cancer. PIK3 mutation is generally stable from the initial diagnosis, but the PIK3 mutation may arise or be lost during the course of disease. This important thing about the PIK3 disease that it contains around 22 or 21 exon, not a large like a BRCA gene, but there is a two domain having a three mutation, two in the helical domain and one or two in the kinase domain mutation, which has around 80% prevalence in all PICA mutation. So usually the PICA mutation or PIK3 mutation is in the routine practice is done by PCR for these special mutation. So if these mutation becomes negative, then they recommend to do by sequencing. So initially they recommended to do by tissue. If the PIK3 is positive and you apply and you started the treatment, then you can follow by the liquid biopsy for its recovery. So there is a different modalities. We already discussed ERPR expression by immunohistochemistry. HER2 you can do immunohistochemistry or by the fish. Fish is the gold standard. The other routine practicing panel recommended for the recurrence of disease. Some of them they are done by the next generation. Some of them they are done by the microarray.
Apologies for the disruption here. So the screen is not working because of the voltage fluctuation. So please give us a few minutes and then we'll resume the talk. Assalamu alaikum ji. So I think there is a voltage fluctuation which may take a bit of time to sort this big screen out. In the meantime, I would request the audience that we have got two screens on both sides. If you just go back on that side, we can resume the session. That would be very kind. So those two screens, if you just seat yourself beside those, you'll be able to see, and then we can resume the session. Okay, so let's restart the
multiplex PCR. There's a special interpretation based on the clinical evidence. So if you have a strong evidence and it has a very strong literature-based evidence, so we classify or we called it the pathogenic. Similarly, the likely pathogenic also have the strong evidence, but those who doesn't have that much strong evidence, like if it is reported in some case report or some case series, so then they report it as a VUS, variant of unknown significance, and some of them they, while if is not having a strong evidence, very low literature evidence, so then they reported a likely benign or benign. In somatic, they also, with these interpretation, if the pathogenic, then they also subclassify, is it a diagnostic marker, prognostic marker, or the predictive marker. So in germline and the somatic, both classification is applied for pathogenic, likely pathogenic, US, likely benign, and then the benign. This is all are the database evidence, classification. There is another important, part to testing these tissue is the tumor percentage of the tissue. So we should select that, tumor or the tissue which has the nuclear content is higher. We should not select those part who has the colloid material or who has the necrotic or the fibratic. So with the nuclear content, high nuclear content, we will get more DNA, and it's more reliable tissue to testing. Another important thing that we should not use the old tissue, like should not, it is not recommended that if you are using the 4 years back tissue from your archive, and there special variant or a special type of BRCA, usually recommended nowadays by NGS, because BRCA is money. They recommended to do by tissue. If the PIK3 is positive and you apply and you started the treatment, then you can follow by the liquid biopsy for its recovery. So there is a different modalities. We already discussed ER expression by immunohistochemistry. HER2, you can do immunohistochemistry or by the fish. Fish is the gold standard. The other, routine practicing panel recommended for the recurrence of disease. Some of them they are done by the next generation. Some of them they are done by the microarray, and some of them they are doing a multiplex PCR. There's a special interpretation based on the clinical evidence. So if you have a strong evidence and it has a very strong literature-based evidence, so we classify or we called it the pathogenic. Similarly, the likely pathogenic also have the strong evidence, but those who doesn't have that much strong evidence, like uh, if it is reported in some case report or some case series, so then they report it as a VUS, variant of unknown significance, and some of them they, while if is not having a strong evidence, very low literature evidence, so then they reported a likely benign or benign. In somatic, they also, with these interpretation, if the pathogenic, then they also subclassify, is it a diagnostic marker, prognostic marker, or the predictive marker. So in germline and the somatic, both classification is applied for pathogenic, likely pathogenic, US, likely benign, and then the benign. This is all are the database evidence, classification. There is another important, part to testing these tissue is the tumor percentage of the tissue. So we should select that, tumor or the tissue which has the nuclear content is higher. We should not select those part who has the colloid material or who has the necrotic or the fibratic.
Assalamu alaikum. So, because of
with the
time constraints, we'll be just holding this presentation for now, and we'll be starting a new session. So our screen is back up and running, so you can come forward as well if you want to. So we'll move on to our next session, which is breast 2. Is going to be moderated by Dr. Saeed Abdullah Javed Bukhari. And our panelists would be Dr. Ataullah, who's chair, and Dr. Jamshed Khan. Please.
Thanks a lot, Dr.
So over to Dr. Abdullah Javed Bukhari.
Thanks a lot. Can you hear me? Hello, can you hear me?
Yes, certainly we can hear you, Dr. Abdullah.
Ji, assalamu alaikum everyone. Welcome back. So now we will be starting our second session on the breast cancer. And our first speaker is going to be Dr. Habib Khan. He's a graduate of Dow Medical College and did his CCT in clinical oncology in 2014. He's a member of Royal College of Radiologists International Committee and is currently working as an assistant professor at University of Saskatchewan, Canada. And he will be giving a talk on the management of early triple-negative breast cancer. Over to Dr. Khan, please.
So, Dr. Abdullah, is it Dr. Habibullah Khan? Dr. Habibullah Khan?
Yeah, that's right. Ji, Dr. Habibullah Khan.
Thank you, Abdullah. Thank you, everybody, for inviting me. Thank you, everybody, for inviting me to talk on this great occasion. The topic I've been given is early stage triple negative breast cancer. These are my disclosure. I'll be talking about anthracyclines, platins, taxane-based therapies, and we're going to
This screen is not very. We can just request the audience to be on the backside to see those screens, and then we can carry on. So I think for the repeated disruption because of the voltage fluctuations, I would request the audience. So please, if you just be on the backside, and there are two screens on your right and left, you'll be able to see the presentation, and Dr. Habibullah will kindly carry on with the presentation if that is okay. Apologies for that. So over to Dr. Habibullah again, please.
That's fine. No, that's okay. Okay, so the contents of my talk today is about the chemotherapy backbone, which included anthracyclines, platins, taxane-based therapies. And then we're going to learn about different regime impact the response and can reduce the risk of recurrence in that. And now, obviously, the most important one is talking about immunotherapies in triple-negative breast cancer. And are there treatments available after neoadjuvant chemotherapy which can improve survival? So I'll be talking about adjuvant treatment. And then quick talk about ongoing trials and the future. So what are the practical implications? We know about neoadjuvant chemotherapy is preferred approach in triple-negative breast cancer. And we know that the combination chemotherapies tends to do better. And now we got immunotherapy such as pembrolizumab, which will add on to the taxane platinum-based chemotherapy. And this allows us to tailor adjuvant therapies to identify people who are at increased risk of recurrence if they have a residual disease. Before I go on, I want to talk about molecular classification of triple-negative breast cancer. We know it is a heterogeneous group, and the clinical phenotype mostly comprises basal-like molecular subtype. But there are other subtypes that have been defined phenotypically, like luminal androgen receptors, mesenchymal type, basal-like immunosuppressed, and basal-like immune activated one. This has the implication how the cancer responds to the treatment. There has been a talk before me which has explained quite a lot about the different types of breast cancer. I'll go back to the basics first. Why do we do the neoadjuvant or preoperative chemotherapy? Everybody knows that last one, that breast conserving surgery, it allows breast conserving surgery and improves surgical outcomes. But apart from that, in triple negative breast cancer, it allows time for genetic testing and related impact. For example, decide when and if to do bilateral mastectomy. BRCA mutation is about in 20% of triple negative breast cancer, which we can identify and plan more for the future. We can assess response rate and in fact provide better estimate of the prognosis and possibly escalate therapy if residual disease is found. Earlier introduction of systemic therapy, we can eradicate a small amount of disease which might have spread outside the primary area. Let's talk about the anthracycline, taxane, and platinum-based chemotherapy, how they evolved. So we know from NSABP B18 trial, there was no difference in preoperative and postoperative anthracyclines. Overall survival at 9 years was almost similar. Similarly, disease-free survival was almost similar. And Fisher and al. Have proved that the downsizing and it allows more lumpectomies to happen. So when we do the neoadjuvant chemotherapy, we are looking at the complete pathological response. CORDSAR has also proved that triple negative, if you do neoadjuvant chemotherapy, tends to do better. Similarly, Carey and Lidika has also shown the patient with complete pathological response tends to do better and have a better outcome. So let's talk about the adjuvant. Why can't we do the adjuvant treatment? A large retrospective review from MD Anderson has proven that if there is a delay in starting the adjuvant treatment for more than 30 days, there's a significant outcome effect and people have a poor outcome. So we have to start something for triple negative, which is aggressive breast cancer, as soon as possible. There's another trial like ABC trial, which look at a triple negative breast cancer subset, exploratory, and they did better, especially when we add the taxanes with the anthracyclines. So let's look at the role of taxanes in neoadjuvant chemotherapy. So early breast cancer trialist group published in Lancet 2012. Similarly, CLB-GB 9433 have proved when we add taxanes to the anthracyclines, the outcomes were better, not only in triple negative, throughout the other cancer, other types of breast cancer. Other thing that we consider about is the dose-dense chemotherapy. Have they proven their worth? We know from CLGB 9741, the AC giving 2 weekly versus 3 weekly, there was a better outcome in terms of dose intense, and the percentage of event-free survival was better. Now let's quickly look into the platinum-based therapies in triple negative breast cancer. What does it do? So when the platinum was added to the neoadjuvant chemotherapy, we achieve increased response rate and survival was improved. So what is new about the platinum? Platinum-induced DNA damage, and it's been proved, and also it has an immune-mediated cell death activation. That plays an important role and open up a new horizon to look into the immunotherapies in triple negative breast cancer. It was proven by the GPAR-60 and CLGB trial, which has shown that when we add carboplatin to the backbone of chemotherapies, and the response rate was significant. You can see with no carboplatin added to the treatment versus carbo, the response rate jumped from 37 to 53%, and it was maintained in the CLGB. The only thing is either you give it 1.5 to 2 AUC carboplatin weekly, or you give 3 weekly. So it has proven there's a significant role of carboplatin in triple negative breast cancer. So let's look at the brightness trial, which is platinum compounds in triple negative breast cancer, and it also incorporated BRCA mutation, BRCA or PARP inhibitor. When you look at it, although it did not prove that the PARP inhibitor improved the complete pathological response, but it does show that when you add carboplatin to the treatment neoadjuvant, we do have a significant response. Here you can see paclitaxel with carboplatin in the first one, followed by the middle one, which had paclitaxel and carboplatin with or without valparib. So that shows that the importance of platinum in triple-negative breast cancer. And it was also proven by the stratified analysis of event-free survival, which when you add the carboplatin, they had a better outcome. And there was a significant difference of about 10%. Does the difference stays with the BRCA mutation, or there was no? This also is proven that all patients benefit from carboplatin. Either they have a BRCA mutation or no. So let's look into the chemoimmunotherapy in its standard of care and stage 2 to 3 triple-negative breast cancer. What was the rationale? So we've gone through that tumor-infiltrating lymphocytes is much more commonly presentation. PD-L1 expression is more in triple-negative breast cancer, and non-synonymous mutations are also present. So these are all the driving factors to consider immunotherapy in this group. The main trials which I picked up to talk about today is GPAR-NIVO, which are using a durvalumab along with nab-paclitaxel, and then nab-paclitaxel with atezolizumab with carboplatin. Similarly, the practice-changing trial, which is the Keynote 522 trial, which was looking at the paclitaxel carboplatin chemotherapy with anthracycline backbone, giving with pembrolizumab or placebo. And Impassion 031 trial is also a neoadjuvant trial looking at atezolizumab with nab-paclitaxel. And you can see down that they all have proven improvement in complete pathological response in triple-negative breast cancer. So let's have a quick look a little bit more in about GPAR-NIVO trial. It is a trial which randomized people having durvalumab versus placebo, followed by durvalumab giving every 12 weeks for 12 weeks and followed by 8-week durvalumab. Here you can see the nab-paclitaxel is there with EC, followed by EC in the control group. When we look at it, overall survival was improved when we add the treatment. Overall survival is 95.2% compared to 85.3%. So it shows that the adding of immunotherapy has a significant impact in neoadjuvant chemotherapy. Now let us talk about a little bit more detail about Keynote 522 study. It is a very good study design, which included the adult patient with newly diagnosed T1C to N1 to N2 or T2 to T4 N0 to N2 disease, which is a high-risk triple-negative breast cancer with good performance status, and tissue sample was available for PD-L1. And they were randomized to go with the carboplatin paclitaxel backbone chemotherapy, which either started with pembrolizumab or without, followed by